Yes. So can we check your audio? And yes, yes,
Yeah. Is the audio fine?
yes. Fine, fine, doctor.
Oh,
Done. Yes, doctor. Thank you so much.
thank you.
So good afternoon, everybody. So we'll start the session now. Welcome you all for the Friday webinar. So today the topic is going to be on life-threatening ECG pattern recognition for everyone. So I'm glad to see you all here. Most of the participants now actively have joined in for this because I know that personally how it is. This topic is very important for the healthcare professionals. So before stepping into the presentation, I'll take you all to the quick introduction about Skills for Med. What are we actually? This Skills for Med have been established since the year 2018, and we have been committing providing comprehensive training program designed to enhance the capabilities of the healthcare professionals. So for now, we have 10,000 plus healthcare professionals who have been trained with us, and 75 plus hospitals have networked with us, and 50 plus post topics have been launched. So we are not limiting now with this 10,000 plus nurses. All the new participants who have come today to our webinar can join our community. At the end of the session, I'll be showing our WhatsApp community where you can get real benefit out of the Skills for Med about all the programs. So coming to the pyramid part, the Skills for Med logo. What is this actually, the learning pyramid? So we have 4 stages. The stage 1 talks about service excellence skills. And that is actually when a healthcare professional steps into the hospital, how to survive in the healthcare professional should have the basic qualities like communication, the etiquette, the professionalism, and also about the infection prevention basics and so on. So we cover all these things. Once you have become the service excellence, you can step up into the core patient care skills. That is about all the procedural skills at the bedside and what all you practice day to day. So it is not about talking about I am competent in one set of skills. It's not about that. If you're competent in all set of skills, you will be called as clinical expert. So that is what we're talking about in the stage 2. Stage 3, you have become clinical expert and become in charge of the department. It's not, it's not an end to you all. You can choose your specialization either, or already you're in the specialization. For example, you are in the emergency department, ER upskilling program, labor room upskilling program. And there is a program called infection control nurse course program, and also as a clinical instructor. Now it's been like for long years, like 15 years being in a position of nursing supervisor, looking for or aspiring to become a trainer. You can become a clinical instructor after doing this program, and that's not the limit. So now it's you have to head towards the leadership. So for the nurses, I would say you have 2 pathways. One is the lateral pathway, another one is vertical pathway. So vertical pathway is becoming a staff nurse, senior staff nurse, in charge, supervisor, ANS, DNS, and then CNO. And that's how the vertical path looks like. Let's imagine the lateral path for the nurses who have already achieved as that in the path. For example, you yourself look into the administration aspect. Nurses solve most of the problem in the healthcare without knowing you into the administrative, in the programs. Take up that role, be in the operation side, and then take your growth as the CEO of the hospital, not the CNO of the hospital. In many of the hospital, there are the nurses to become a CEO of the hospital. So that is about 2 paths in the leadership skill. So this is all about the Skills for Med learning pyramid. And I have an announcement. Just a moment. Yeah, I have an announcement. So this is about infection control nurse course program, which I was talking about, and that is a self-paced learning. And this is the offer price which is running, which you can see in the screen. And the course highlights are comprehensive. We have seen many nurses who have underwent this program have transitioned their career from the bedside into the infection control nurse course. And to know more details about our course, you can contact Ms. Jayanti, our admin manager, and her number is on the display. And you also can visit our website, which is www.skillsformed.com. So coming to today's presentation. So you can see, we can see like a lot of participations have come because of the topic. So we have a special guest today who is Dr. Wasim, the head of Department Emergency Medicine at Sundar Medical Foundation, Chennai, where he also serves as a clinical head for patient safety and quality. He's a principal assessor for NABH, Quality Council of India, and brings extensive expertise in both emergency and medicine and healthcare quality. And he is a certified BLS and ACLS instructor by the American Heart Association and certified ATLS instructor by the American College of Surgeons. He is also an examiner and fellow of the Royal Emergency in UK. Dr. Wasim is a life member of the Society of Emergency Medicine India, and his leadership has been recognized with the Leadership Emergency Medicine Award at SEMICON 2023. He also plays an active role as a coordinator of the Chennai Emergency Medicine City Meets. Beyond these achievements, Dr. Wasim has been a speaker at many national conferences and has contributed valuable publications in Emergency Medicine Journal. We are honored to have you here, sir. Welcome you, Dr. Wasim.
Thank you so much for the kind introduction.
Yes, thank you so much, doctor. And another, unfortunately, we'll not be having another speaker, Dr. Parivalvan Rajvelu, because of his unforeseen reasons. So as you all know, Dr. Parivalvan is a consultant surgeon and he is the visionary founder for Skills for Med, and his vision through accessible high quality training with a strong focus on patient safety and clinical excellence. And also he is a passionate advocate for healthcare quality, and Dr. Pari has a key role in 𝐃𝐞𝐜𝐬𝐧𝐠, and he contributes as a mentor, national speaker, GC committee member, and serves as a chair of EndoSafe activity promoting endoscopy safety across India. And his leadership and his deep-rooted and extensive clinical experience, ongoing research, and international presentations. So through Skills for Med, he continues advanced healthcare outcomes by equipping professionals with world skills and practical knowledge. Dr. Parivalvan's unique blend of clinical expertise, clinical skill, and academic rigor and systemic level thinking makes him an inspiration and change maker in today's healthcare landscape. So doctor is not there, but still I have to give an introduction about him for the benefit of the newcomers to know who is Dr. Pari, who is the actual visionary leader. And at last, I am Stella Townsend. I am the training manager in Skills for Med. And once again, I welcome you all, the participants who have come for the session. So let us begin the session. So what you're looking at this, so the ECG strips flowing from the ECG equipment. So I wanted you all to give a response in the chat box, thumbs up or the yes, if you have ever been felt like this, what I'm going to say. After looking at the strip, you're feeling, can I have someone to come here and could interpret this for me? So have you ever felt that? So drop in the chat box. You can put the thumbs up or, you can put up yes. So just for the basic analysis, okay? Yes, thumbs up is flowing on the screen. Thank you so much. And thank you so much. Many are putting up in the chat box. Let it go. And, it's about, the monitor that everyone fears when you are all in the healthcare, in the sector. So don't worry. Today you're in a good company. You're going to learn something like after the session, what you're going to learn. So it's about like how to interpret the ECG or the warning signs. So that monitor, it shows like almost 78% of healthcare professionals, including many physicians, admit they feel uncertain when they are about to interpret the ECG strips in emergency situation, not in the calm situation. So during the situation, they feel so scared to interpret something which is very important. So, but here's the problem. what actually happens, the reality check. When you look into the ECG, you would have gone through all these things. The ECG monitors are there in everywhere. It is not about ECG is limited only to the critical care unit. It's in ICU, it's in emergency, of course, and it is also in regular wards. And healthcare professionals are encountered to see this ECG readings in almost in every day in the clinical time. And 60% of healthcare workers report feeling unprepared, and they are not able to recognize the life-threatening rhythms during the time of in the emergency situations, or when someone asks them to interpret it very quickly, they feel so difficult to do that. So this is the reality check. What happens? Of course, most of them think like, even to someone to come in and interpret the ECG, almost 12 minutes of delay is happening to interpret that. What happens with the 12 minutes delay? So what happens is like, I'm sorry, in cardiac arrest, the brain death occurs in 4 to 6 minutes. So imagine we are going to have a 12 minutes of lag to cardiologists to come and look into the ECG and to interpret what happened to the patient. So that waiting time, almost 4 to 6 minutes, the patient brain is dead. So we literally cannot afford in waiting time in the cardiology consult or in the emergency situations. So we have been, why are we so afraid because of that? So because we have certain myth in our mind and some understanding which we can break today after this session. We think that we have to have years of specialized experience in the cardiology unit, or to be a cardiologist, especially to interpret the ECG. And also, we itself think we need to have a deep understanding of cardiac electrophysiology, and we also have to possess knowledge of different rhythm types and ability to calculate intervals and analyze complex waveform. Of course, these all 4 things are very important, but it is only true when in the case of comprehensive diagnosis and for the treatment planning. For the immediate interpretation and to communicate with the doctor and to take certain action, you don't have to qualify in all 4 things what we were talking about and what we are thinking still in our mind today before logging into this session. So this is like, what happens when we don't look at the ECG interpretation. 2 a.m. emergency department, the young resident sees the chest pain patient with abnormal rhythm. So, but doesn't recognize the STEMI because he would have got panic, or he is not sure about what is this ECG actually speaking about, and he is waiting for the cardiologist consultant. What's going to happen? Already I've told you what happens if we delay time in interpretation. So patient has massive heart attack, door to balloon have been delayed with 45 minutes. Actually, it is not a good thing for the patient. So we are compromising the patient safety here. So because of the delay. So next case scenario, this just a scenario what I wanted to share if we lag in ECG interpretation. So this is a small clinic. General practitioner seeing elderly patient. The ECG showing complete heart block. The rhythm itself says, but he is mistaken that saying that normal aging bradycardia. So misinterpretation has been happened. The patient collapsed in the parking lot 20 minutes later. So that's what happened to the patient. So these all things what happens, when you don't know to interpret the ECG. So I just want to say why we have taken this session for you all to understand or to learn the ECG pattern that saves life, and also practice recognizing them in real ECG strips, know exactly what to do when you see them, and also feel confident approaching any ECG monitor. So after our expert, 30 minutes of session is going to be Dr. Wasim's session. So after his session, I'm sure you all will be able to practice in your daily practice. You'll be able to at least interpret the, the dangerous signs which are shown in the ECG pattern in the monitor from tomorrow onwards. For that, as soon after the session, you have to recollect and practice in your ECG papers, put into the papers, then start acting on that. So this is all about how you're going to build your confidence today after this session. So before Dr. Wasim's session, so we'll just take up our usual poll. So I'm going to launch the poll here. Yes, it's all about 5 questions. Basic questions. I request all the participants to jump into the poll and start answering to it. You have 3 minutes left for it. This is not regarding your knowledge awareness. It's about the understanding. So start answering for these questions. Already 30 seconds over. I request all the participants to answer to this poll question. Thank you so much. You have 2 more minutes left. So you have completed 2 minutes. You have 1 more minute left. You have 30 seconds left. Thank you, Ms. Tilagavati, who have said you have completed the poll. Thank you so much. It's very quick. I think so. It's very easy, to complete the poll. It's very basic, simple questions to understand the webinar participants. Yes. So I'm going to end this poll here and share the results. So, Dr. Wasim, you can even come and join us, join here in the webinar poll. Are you able to look at the poll
Yeah,
results?
I'm able to see it. Yes.
Yes. The first question what we asked about is like, usually we compare any kind of question with a movie backup. Like when you see an unusual ECG rhythm that doesn't look normal, your first instinct is like, which Hollywood movie character? So most of them about, I think 31% of people have said like Mission Impossible. I'll figure out this out step by step. And Fast and Furious, I need backup right now. And very minimally, they have said, no, I'm pretending I didn't see that. And 21% have said The Flash, let me run and get someone experienced. And, the 15% of people have said like time to investigate every detail. So this is about the first question. And the second question, what we asked is about current awareness level. How would you rate your current understanding of ECG rhythm? So we have, like complete beginner, ECG sounds like a new streaming service for 23%. And about 37% is like no basic awareness. I know it, monitor heart activity. And moderate knowledge, I can identify a few basic rhythms. And 10% is like advanced, I regularly interpret ECG in my practice. And we have 1% was expert level, I dream in P waves and QRS complexes. Doctor, you got an idea about our webinar participants now?
Yes, I've got an idea.
Yes. Yes. And third question is about experience level assessment in your professional role. How often do you encounter the ECG? Is that daily? Yes, almost 53%. So I have said already, daily you'll be looking into this ECG strips. It's daily we have most of the participant. And 20% is about weekly, occasionally during patient assessment, and remaining all it's like partially distributed among monthly, rarely, and never is 4%. Okay, I really want to know from which department you are. New territory for me. Okay, done. And fourth question is about learning barriers identification. What's your biggest challenge when it comes to ECG interpretation? The real question. So about 51% have said difficulty distinguishing between normal and abnormal patterns. So very simple, made it very simple. And most of them have said, lack of hands-on practice opportunities. And quite a few people have said like technical terminology feels overwhelming, and time constraints in busy clinical settings. So that's the difficulty, and fear of making incorrect interpretations. And a few members have said limited access to quality learning resources. And the last, the question is about exposure and learning goals. Which ECG rhythm scenario would you most likely to confidently handle after today's session? So it is about, I think, recognizing life-threatening arrhythmias in ER, and also you're anticipating you'll be able to identify normal versus abnormal. Of course, you will be able to figure it out after the session. And understanding what to do when the monitor alarms go off. Yes. Explaining ECG findings, knowing when to call for immediate cardiology consultation. Yes. Thank you so much for all your active participation. So thank you so much. And without any delay, which you were eagerly waiting for since this week's will be looking forward. I'll stop sharing here, Dr. Wasim. You can share your presentation. Thank you so much, Doctor.
Yeah, I think you need to enable sharing.
Okay. Jay, please facilitate that.
Yeah, is my screen visible?
Yes, doctor.
Okay, so thank you for the kind introduction, and thank you everyone for joining, and thank you Skills for Med for giving me this opportunity. So today I'm just going to talk about how I can create a little bit of awareness of how you can recognize abnormal ECGs. So being in the emergency, I see abnormal ECGs day in and day out. So I thought we'll put up a few abnormal ECGs and make it easy for people who see ECGs to identify the abnormal one. There's a disclaimer, I cannot make you an expert in ECG within this 1 hour. It takes a long term to learn, and I'm still learning. So I can, in this 1 hour, my aim is to make the audience aware of identifying abnormal ECGs. So my agenda today is an introduction, talk to you about mainly the rate and rhythms, some abnormal ECGs, and take it from there. So the introduction to ECG, what is this ECG basically? ECG is basically, there is an electrical circuit inside the heart, and there is also the blood flow in the heart. So electrical circuit basically starts from SA node, AV node, and goes through the bundle of phase. So this is nothing but represented on the ECG, which is your P wave, where your atria contracts, and then you have your QRS, where your ventricle contracts, and then you have your T wave, which is basically your ventricular relaxation. So this wave, P, QRS, and T wave is the basis of an ECG. So there are other segments. Now we look at PR segment, QRS complex, ST segment, and T wave and U wave. There are various waves and intervals. So we are more concerned with regard to ST segment, T wave. These are the important ones. So to begin with, we just start off with what is what, the important ones. Again, P wave basically means atria is contracting. QRS complex means the ventricle is contracting. The T wave is the ventricular relaxation or the repolarization. This is a wave needs to have the basic P wave, QRS, and T wave for it to be called a normal sinus rhythm. Okay, the rhythm is starting from the sinus node. This is a normal sinus rhythm. Now, when we look at this, we need to be able to, when we take a rhythm strip, sometimes when you take a rhythm strip, we may not be able to see what is the heart rate. So to get a fair idea, we should know that this rhythm strip, when it spools out, it runs at a rate of about 25 mm per second. So each big box is about 5 mm. So about 5 big boxes are 1 second. Now, if you want to know the heart rate, so you know how much is there in 1 second. So there's 1 beat in 1 second. So you calculate that for 6 seconds, calculate the entire heart rate for about 6 seconds, and you calculate the heart rate for about 6 seconds, and then you multiply it by 10 because you want to know the heart rate for 60 seconds. This is an easy way to calculate heart rate. So when the heart rate is irregular, this is really useful. So first thing, you see a rhythm, you're a rhythm strip, someone is asking you, okay, so what is the heart rate of the patient? Is it slow? Is it fast? Counting the heart rate for about 6 seconds and multiplying it by 10 will give you a value. Another way to calculate is look at the number of large boxes between two R waves. So if you got number of large boxes between two R waves, you have about 5 boxes. So use the formula 300. This is the formula 300 by number of 300 divided by 5, it will give you 60. 300 divided by 4, it will give you 75. 300 so this is one more very easy way of calculating the heart rate. So just use the formula 300 by number of large boxes between two QRS complexes, basically the RR interval. This is another easy way to calculate the heart rate. Now let's look at abnormal ECG patterns. So pattern recognition, as I told you, I'm not going to make you experts. I'm just going to make you identify life-threatening issues so that you can do life-saving. Take life-saving measures. If it is very chaotic, okay, just looks like a disturbance. The ECG looks like a disturbance. The patient is most probably having a ventricular fibrillation. I'll talk about all these rhythms in more detail. Does it look like sharp teeth? Probably ventricular tachycardia. Are there unusually long pauses? Most probably it's a bradycardia with a heart block. Do you see mountains? It's most probably a heart attack. If it's dangerously slow, again, it's a severe bradycardia. So some immediate action needs to be done. So we'll see all these waves in detail going forward. Now I have an ECG rhythm here. I've told you how to calculate. So it's 300 divided by the number of large boxes between two R waves. So can someone put in the chat box, what is the rate that you can calculate based on this? So you've got 1, 2, 3, 4, 5, 6, almost 6 or 6.5 boxes between two R waves. So you can put that in the chat box as well.
They have started answering.
Yeah.
50,
okay.
50, 50.
Exactly. Yeah. So now you know how to calculate rate. Fantastic. Okay. So 300 divided by number of large boxes. Great. So now 50. So now what is the name of this rhythm? Is it bradycardia? Is the rate less than 60? It is called bradycardia. So once you calculate the heart rate, is the heart rate less than 60? Yes, it is bradycardia. Now, now to tell whether this bradycardia is normal or abnormal, you just have to look at the waves. Is there a P wave? Yes, there is a P wave. Is there a QRS? Yes. Is there a T wave? P wave, QRS, and T wave. It's a normal. It's a sinus rhythm. It's starting from the sinus node. So if there is a P wave, QRS, and a T wave, it's a sinus bradycardia. So if it is not, then you need to get help. So you can have some sort of a heart block. So if there are really long pauses, there are missed beats, there's probably some sort of a heart block going on. So you need to be able to identify heart blocks. So this is normal sinus rhythm. And then you have your sinus bradycardia if you have a P wave, QRS, and T wave. Otherwise, it's an abnormal bradycardia. Now, a bradycardia is heart rate which is less than 60 with normal rhythm and spaced. It can be normal in athletes. So if you see a patient who's sleeping, you might find bradycardia. Nothing to panic about. If it can be normal in athletes, young people, no problem. If your patient has symptoms like chest pain, dizziness, or fainting, you need to get the entire 12-lead ECG. What I'm showing you is a rhythm strip. You need to get the 12-lead ECG, and based on what abnormality is there, we need to intervene. So ECG helps us determine if the sinus bradycardia is benign or requires medical investigation. There may be a electrolyte problem or a myocardial infarction. Now, this is one easy flow chart. I'm not going to discuss detailed flow charts. There are only two flow charts I'm going to discuss today. One is bradyarrhythmia, one is tachyarrhythmia. This is very simple. You have a green box. The green box, anyone and everyone can do. You identify a bradycardia. You think the patient is symptomatic. Put the patient on some oxygen. Make the patient sit up. See whether the patient is breathing well. Put him on a cardiac monitor. Get a 12-lead ECG. The green box, everyone can do. Red box is decision-making box. Is the patient having hypotension, altered mental status, signs of shock? Is he in hypotension, or is he having chest pain or acute heart failure, signs of pulmonary edema? Yes, then you can think of giving a trope, and you give a 1 mg bolus and you can repeat maximum 3 mg, or you might have to think of drugs. No, you can monitor and observe. This is all you need to do for management of bradyarrhythmias. So now one more interesting ECG. So is this a sinus bradycardia? Definitely not, because I can't see a P wave. I can see a P wave, QRS, and a T wave, but then here there's a P wave, there's a mist, there's nothing there. And there's another P wave, there's nothing there. So what is this? This is something dangerous. Can someone put in the chat box, if someone has identified it?
One answer is there, like AF.
Yeah, correct. No, so heart block. So someone has put heart block, someone has put complete heart block.
Heart block is also there. Miss Abhinay have answered as heart block.
Yeah.
Yes.
So this is basically a complete heart block. So now, how did they identify this complete heart block? So complete heart block is basically a block with regard to conduction. There's no conduction happening between the SA node and your AV node. So what happens is basically you have a P wave, and you have your P waves are here, P regular. The PP interval is constant. The RR interval is constant. And there is no correlation between P and QRS. There is basically atrioventricular dissociation. So this is how you identify a complete heart block. So the PP will be constant. The RR will be constant. PP is constant, RR constant. No correlation with P and QRS. Patient is having a complete heart block. This is a dire emergency, needs immediate pacing. So either we can do transcutaneous pacing or transvenous pacing. So this patient has to be quickly taken up for pacing. The cardiologist needs to be involved quickly. Okay, so let's see one more. Yeah, PP is constant, RR is constant. No correlation with P and QRS is heart block. Anywhere, if you have a missed beat, it might be a second-degree heart block. So I'm not going too much in detail into heart blocks. We're just going to talk about few life-threatening arrhythmias. Okay, now I've put one more rhythm here. Can anyone, based on our earlier formula, 300 divided by number of large squares, can you tell me what is the rate? Yeah, there are heart rate.
Yes, yes, doctor. 150 the answer.
Start answering. Wonderful. So yes, heart rate is around 150. So
one person have answered a sinus tachy, 150
wonderful.
heart rate.
Wonderful. So this is a sinus tachy. So how do I say it's a sinus tachy? Heart rate is more than 100, and I have a P wave, I have a QRS, and I have a T wave. So this is nothing but a sinus tachycardia. So when I have a sinus tachycardia, I need to to call it a sinus tachycardia, heart rate should be more than 100, normal P, QRS, T wave. And what could be the reason? The reason could be physiologic also. It can be normal. Patient who's done exercise, patient who's under a lot of stress, patient is having fever, is dehydration. So all these can cause sinus tachycardia. So we need not worry when there is sinus tachycardia. Apply any sort of algorithm. Start calling for help. Is it a fever? Manage the fever. Is it dehydration? We need to manage the fever. Is it sepsis? Then escalate. Is this because of anemia or hyperthyroidism that it's not settling down? All these can be sinus tachycardia. Sinus tachycardia, if the patient is admitted itself with a sinus tachycardia and the doctor says it's okay, that the patient will have sinus tachycardia because of some reason, probably hyperthyroidism or anemia or something, then it is okay for the patient to have sinus tachy. Otherwise, if it's a newly developing sinus tachy, we have to identify what is the reason and treat the reason. Any rate more than 150 is alarming and abnormal, has to be intervened, even if it is sinus tachy continuously more than 150. Okay, one more rhythm. Let's see whether you can identify this. AF. Okay, we've got lots of people AF. So how did these bright people identify this as AF? For that, let's compare it with a normal sinus rhythm. Normal sinus rhythm has a P wave, QRS, and a T wave. But this rhythm on top has a fibrillatory. There are fibrillatory P waves. There are a lot of P waves, and they are fibrillatory P waves. You can't see a clear-cut P wave. And then the RR is irregular. Okay, the RR is irregular. So it's an irregularly irregular rhythm. To say whether a rhythm is regular or irregular, we look at the QRS complexes. We mainly look at the QRS complexes to see whether the rhythm is regular or irregular. Here it is irregularly irregular. So a fibrillatory P wave is not, P waves which are not clearly defined, and then you have your irregularly irregular QRS complexes is atrial fibrillation. Now, when we talk about atrial fibrillation, it's an irregular heart rhythm, causes chaotic irregular atrial rhythm visible as absent P waves or fibrillatory P waves. The atria is basically quivering, it's shivering, okay, instead of contracting properly. So when the atria is not contracting properly, you have blood accumulating there. So atrial fibrillation by itself will not harm anyone, but problem is the blood being accumulated in the atria can cause clots, and that clot, when it moves, can cause strokes. So whenever we identify atrial fibrillation, immediately it has to be reverted. Either you do rate control or rhythm control and bring it back to normal to avoid serious complications, which are strokes. So that is the major complication. Okay, let's see one more ECG. So again, I've shown you one more ECG. This is again atrial fibrillation. How do you identify it? Heart rate which is irregularly irregular. Okay. So now that we've gone into tachycardia, this is the second algorithm I'm going to share today. That's about it. I'm not going to go into more detailed algorithms. This is the second algorithm. Again, very simple. The first question is this appropriate? If the heart rate is more than 150, apply this algorithm. Otherwise, it's just going to be sinus tachycardia. Same thing. Put the patient on a monitor, check the patient's blood pressure, check his oxygenation, put an IV access, get a 12-lead ECG. The red box is the most important thing. Does the patient have shock? Is he in altered sensorium? Is there signs of shock? Ischemic chest discomfort? Yes. If the patient is hypotensive with such a rhythm, then you have to think of giving the patient a shock, which is called synchronized cardioversion. Again, this, if you've attended an ACLS workshop, you will be given training on how to give a synchronized cardioversion. Small energy, synchronize it so that it gives at the peak of the hour. The shock is given at the peak of the hour, not any other time, so that this rhythm reverts to a normal sinus rhythm. If the patient doesn't have features of shock, the red box is the important box, decision-making box. Then see whether it is a wide QRS or narrow QRS. So our atrial fibrillation, which we saw, was a narrow QRS. So it's not a wide QRS, it's a narrow QRS. So you can think of vagal maneuvers, adenosine beta blockers, or calcium channel blockers. If it is a new onset of atrial fibrillation, we can think of giving amiodarone. The same way, if it is a wide QRS, you give antiarrhythmic infusion, which is amiodarone. If it is a narrow QRS, you can think of vagal maneuvers, adenosine or beta blocker, and calcium channel blockers. So this is the only other algorithm I'm going to discuss. I'll show you another rhythm. So narrow complex, fairly regular, okay, but there is something wrong with the P wave. What do you think this is? Let's see who answers first. Yeah, we've got a lot of people answering. It's atrial flutter. Yes, we've got a lot of people answering atrial flutter. This is a sawtooth pattern. You're seeing you're seeing P waves as as atrial flutter. So basically, the atria are contracting, but it is more than the ventricular rate. So this happens in a 3:1 or a 2:1 ratio. So this is an atrial flutter. Here again, the main concern is if the patient is in shock. If the patient is in hypotension, we give shock. If the patient is not in hypotension, we can give medications such as beta blockers or calcium channel blockers. Again, our agenda here is not to make you experts in treating those. Main agenda for today is helping you identify the rhythm. So this rhythm is a atrial flutter. Look for that sawtooth pattern between the R waves and you can identify atrial flutter. Mostly a regular rhythm, rarely can be irregular. So now I've put up a normal sinus rhythm, atrial flutter, and atrial fibrillation so that you're able to identify. These are all narrow complex tachycardias which are easily confusable. So I've put them all three together so that it's easy for you to identify. Now, atrial flutter displays a distinctive sawtooth pattern. Again, because of heart disease, hypertension, prior cardiac surgery, all these can cause atrial flutter. Beta blockers or calcium channel blockers, if it continues to persist, nowadays we have catheter ablation, we have electrophysiologists. So these are cardiologists who are specialized in electrophysiology who do something called catheter ablation. There's basically an accessory pathway which is there, an additional pathway in the heart which needs to be ablated so that the normal sinus rhythm takes over. So let's see another case, a 45-year-old lady. She's got palpitations, difficulty in breathing, extreme weakness, and her BP is very low. You get a patient whose heart rate is so high, BP is so low, automatically, you remember the algorithm, the green box. Prop them up, give them oxygen, put them on a monitor, 12 lead ECG, IV line, oxygen, okay? And then look at the monitor. A monitor shows a, can anyone answer? Let's see who answers. Yeah, we've got Anburaja, Bhargavi, all of them answering. Yes, wonderful. So this is a ventricular tachycardia. This is a broad complex tachycardia. So I told you earlier, if you see shark tooth, these look like the teeth of a shark, okay? So if you see shark teeth, this is a ventricular tachycardia, monomorphic ventricular tachycardia. Immediately we need to intervene. So when we look at ventricular tachycardia, you will have ventricular tachycardia in three situations. One is patient will not have pulse. Ventricular tachycardia without a pulse. You will defibrillate. You will give the highest energy shock possible, continue CPR. Second scenario, you will have a monomorphic ventricular tachycardia, but the patient is in hypotension. You will do something called synchronized cardioversion. You will synchronize and you will give a lesser energy, probably around 120 to 150, 100 to 150 joules. You will do synchronized cardioversion. Supposing you have the same patient who's having a good blood pressure, then you can think of medications such as amiodarone. So on antiarrhythmics, you can think of antiarrhythmics. So whenever you see these shark teeth, you'll think of three options. So one would be no pulse, start CPR and give a defibrillation. If the other is if the patient has hypotension but has a pulse, you'll do synchronized cardioversion, lesser energy, but it's basically a lesser energy shock. Patient has a good pulse, good blood pressure, has a monomorphic ventricular tachycardia, think of giving medications such as amiodarone antiarrhythmics. Okay. Another scenario, 65-year-old diabetic and hypertensive, you got chest pain, restless, hypotensive, and tachycardia. Okay, this is there on the monitor. Let's see who answers. We've got a lot of people saying VT, SVT. Yeah, Prasanna. Everybody's saying VF or VT, but few of them have started saying SVT. So this is supraventricular tachycardia. You have broad complex tachycardia. If you have a broad complex tachycardia, it would be ventricular tachycardia. A broad complex is usually ventricular tachycardia. If you have a narrow complex tachycardia, like the one which you see, this is a supraventricular tachycardia, which is what we call the SVT. So when you have SVT, how do we manage it? So when you have SVT, again, If the patient is hypotensive, you can do synchronized cardioversion. If the patient has a normal blood pressure, you can give drugs such as adenosine to revert the rhythm. Otherwise, if it's not reverting with adenosine, you can think of beta blockers or calcium channel blockers. Okay. Now we've got a 25-year-old in the emergency department with palpitations, restlessness, breathless. The BP is very low, 60 query, pulse rate of 166. This is there on the monitor. Let's see how many of you answer. And now I want the treatment also, because I've told you the treatment. Yeah, everybody's answering right. It is atrial fibrillation. But I told you the blood pressure is very low. So what?
Yeah, one person answered amiodarone, doctor.
Yeah, cardioversion, exactly. So people have started saying cardioversion. So you will, if the BP is low, you will do synchronized shock, which is synchronized cardioversion. If the BP is good, the patient is stable, then you will use medications. Medications can be in narrow complex tachycardia. Here, irregular narrow complex tachycardia, you can think of beta blockers or calcium channel blockers. You can also think of amiodarone. Some people have answered noradrenaline. Yes, that may be later on, but here immediate management would be here atrial fibrillation. You think of here this patient synchronized cardioversion. If the patient's blood pressure was good, then you can think of drugs such as amiodarone, beta blockers, or calcium channel blockers. Good try and good participation from the audience. So now we've got one more case scenario. 55-year-old man comes to emergency with severe chest pain, collapses right in front of you. There is no pulse. What would you do? Let's look at the rhythm. Now, let's see how many answer VF. Yeah. So shock, some code blue. Yes, someone will call a code blue. Very good. Call for help. Very, very important. And the other is saying shock. So shock is a very broad term. You either do defibrillation, which is take the paddles without pressing the sync button, without pressing the synchronization button, you give a shock. But if you find VF, you do defibrillation. If you find the same thing in atrial fibrillation, if you find atrial fibrillation, but patient has a pulse, but in shock, you will do synchronized cardioversion. So here we are having ventricular fibrillation, and the right answer is defibrillation, immediate defibrillation, call for a code blue and start CPR. Wonderful, wonderful audience we've got today. Okay, so ventricular fibrillation, again, the heart rate is not easily calculatable. It's quite high. The rhythm is irregular. It is a chaotic rhythm. So I told you, if it is chaos, call a code blue. If the rhythm is chaotic, call for a code blue. You will have to defibrillate the patient and start CPR. This rhythm means that the heart is quivering. Okay, the ventricles are quivering. So when the ventricles are shivering or quivering, they cannot contract well, and there will not be any output. So right action would be to defibrillate immediately, because the chances of survival come down by 7 to 10% with each minute of VF. So every minute you waste, okay, I'm not sure whether to shock or not. Let me wait. Whether to defibrillate or not. Let me wait. Let me confirm with someone. With each minute, the chances of survival come down by about 7 to 10%. So the person noticing this first should immediately go and defibrillate. Now you have a 29-year-old football player who collapses on the ground and rushed into the hospital, no pulse, nothing. Okay, so what is the ECG? Let's see how many people get it right. Ventricular tachycardia, yes. So now as we go, this is monomorphic ventricular tachycardia because the shape is the same. Monomorphic ventricular tachycardia, call for help, code blue, wonderful. Monomorphic ventricular tachycardia, and we are going to give a shock. So what shock is it? Is it defibrillation or is it cardioversion? So defibrillation. The patient does not have a pulse. So when we have ventricular tachycardia, monomorphic ventricular tachycardia, there are 3 scenarios. No pulse, immediately start CPR, defibrillate the patient. Use the highest energy, take the paddles, shock the patient. You have monomorphic ventricular tachycardia, but the patient has pulse, but the BP is low. You can do synchronized cardioversion. Lesser energy, the rhythm will revert. So you do synchronized cardio. Monomorphic ventricular tachycardia, patient has a good pulse, normal BP, then you will use medications. You can use amiodarone. You use antiarrhythmics such as amiodarone or lidocaine to revert it. So that is you might see the rhythm, but identify, is the patient having a pulse, no pulse in hypotension, or I mean no pulse, having good pulse with hypotension, having a good pulse and good blood pressure also. So now how would you manage these three situations? Very nice. All the audience are very active. Very nice. So the right answer would be to defibrillate 150-200 joules. Again, the chances of survival will come down very rapidly with pulseless VT or VF. So you have pulseless VT and VF, immediately defibrillate and start CPR. Let's see how many of you, I have not taught you this, but let's see how many of you say what this is. You're waiting for the monitor to start. Yeah. Few of you answered asystole, few of you answered flat line. So the right answer is flat line, because you have to follow flat line protocol, meaning is the monitor connected to the patient? Is the leads connected to the monitor? So they should be connected to the patient, the wire should be connected to the monitor, the right lead should be connected. Sometimes when you connect a defibrillator to the patient, it will be in paddle mode. So if the patient may be unconscious, you will start CPR for the patient who has a pulse. So first thing is follow flatline protocol. Check whether the lead is the leads are connected, whether the patient is connected properly, whether you've selected the right lead, and identify whether the patient has no pulse, and then start CPR. Okay, and adrenaline. That's about it. CPR and adrenaline. Wonderful. So this is our asystole. Now I thought the last we've come to the end of our lecture. The last topic. So let's see how many of you identify what this is. Does anybody see mountains in the ECG? Are you able to see mountains? Okay. Yes. ST segment elevation. So this is a ST segment elevation MI. Okay. So people are able to identify ST segment elevation myocardial infarction. So what is this basically? When there is a myocardial infarction, basically patient is having a heart attack. Initial stage, you will have a I told you about P wave, QRS and T wave. So the T wave alone will start becoming hyperacute, or you'll have a tall T wave. So what we need to do is, very rarely patients will come in so early where you're able to identify a hyperacute T. These patients need to be observed and an ECG needs to be repeated so that we can see the next phase in acute MI, which is nothing but the mountain which I talked to you about. The mountain is nothing but the elevation of the ST segment, the ST segment elevation. So that is what we are now looking for. I told you about sharp teeth. I told you about mountains. This last thing is about mountains, where we roll out MI. But remember, a 12-lead ECG does not rule out MI. We need to keep repeating ECGs. We need to do blood enzymes. Sometimes ECG may not show an MI, but an echo and enzymes may show an MI. So ECG, we need to learn, but again, this is not 100% accurate. So let's look at some ECGs. So when we look at ECG, when we look at this, at these mountains, we need to look at where on the ECG they are. So this is your ECG, lead 1, lead 2, lead 3, AVR, AVL, AVF, V1 to V4 and V5, V6. If it is there in 2, 3 AVF, it is inferior wall myocardial infarction. Okay. Usually the RCA is affected. If you have it in the lateral leads, it's 1 AVL alone. Mostly it will be associated with V5, V6. V5, V6, 1 and AVL are lateral leads. So it's more of left circumflex involvement. And if you have V1 to V4 ST segment elevation, it is more of anteroseptal LAD is affected. So wonderful. So this is how you identify what sort of MI it is. Now here you look for your ST segment elevation in these leads. Now, after this knowledge about where your ECG leads are, can anyone say what ECG this is? You're looking for mountains. Yes, we know this is an MI. Now, where are those mountains and which leads? Wonderful. We've got people answering. Yes, anteroseptal MI. Wonderful. Okay. So you also, now in this ECG, if you look at 2-3 AVF, you will have reciprocal changes. Wherever you have those mountains, you will have valleys nearby. Okay. So your 2-3 AVF, you have ST segment depression, which is nothing but reciprocal changes. Can anyone try this ECG? Let's see who answers. You see the mountains? Yes, we are able to see the mountains. Where are we seeing the mountains? Inferior leads. Wonderful. So you're seeing the lead, you're seeing the MI in second, third, and AVF. 2-3 AVF means it is an inferior wall MI. And you will see reciprocal changes. You're seeing reciprocal changes in AVL and one in AVL. Fantastic. Okay. Let's try another ECG. Okay. Anterior wall only? Is there the mountains confined only to V1, V4? Everyone says anterior wall MI. Okay. There is some amount of ST segment elevation in one in AVL, so it's an anterolateral MI. Yes, it's involving the entire anterior wall and even in the lateral also. We've got elevation in V1 to V6 as well as one AVL. Wonderful. So to conclude, ECG readings must be considered alongside patient symptoms. You have a patient sleeping peacefully, heart rate of 50. Okay, I learned in the ECG workshop, that ECG class, that we have to put him on oxygen. We have to put him on, don't wake up the person. So you have to consider it along with your patient symptoms. The patient is comfortable. He has maybe he's an athlete. Okay, maybe the patient is hypothyroid. So ECG readings must be considered alongside patient symptoms. To master, I've just told you about 5 or 6 important ECGs which can be life-threatening. So every minute counts. So I've given you some hints on how to. I hope this was a good refresher for people who don't regularly see ECGs. So mastering ECG requires ongoing practice. So even if you are into some other field of practice, whenever you see any patient who has an ECG in the file, take the ECG, look at it, and try to interpret. So unless you do that continuously, you won't. It's very volatile, and you keep forgetting it. So thank you all for the great opportunity, and thank you for being such a wonderful audience, and the participation is really great. So the floor is open for questions.
Yes, thank you so much, doctor. And why I have this smile on my face is like all the heartings and thumbs up and all the wishes are running over the screen for you after the session. I think
thank you so much.
Yes, all the participants were enjoying the session, and I could see the active participation. Usually, you used to have the poll and the interactive question in between, but throughout the session, you have made everyone to interact in the chat box to put up the answers. And I think, it's not about, as I've said in the beginning, it's not about becoming a cardiology expert overnight. It is about identifying the emergency signs in the ECG. So that's what Dr. Wasim was taking us through. And thank you so much for this insightful session, Doctor.
Thank you. Thank you for the opportunity.
Yes. And I have 2 more announcements, and then right away we'll get back to the Q&A portal. I'm just sharing my screen. So this is the announcement. So upcoming webinar, I would like to have the quick announcement. Then we'll have, if you want to have any direct question with Dr. Wasim, or you can even get ready your questions in the Q&A portal. Meanwhile, this announcements will be going on. So today we have completed with this decoding a basic ECG. And next week, we'll be having how to give a perfect handover using the ISBAR framework. And third week, it's about the theme related to learning from incident errors. And the topic is about spotting these subtle signs of deterioration to prevent the cardiac arrest. And the last week, the special edition, stay tuned. We'll be announcing the guest speaker very sooner, before Friday 26th. Okay, so this is all about the announcement for this month webinar topics, and we have come to an end. And now the time for the Q&A session. The QR code which is there on the display is to join our WhatsApp community. You can scan this QR code and you can join our WhatsApp community to know more updates about Skills for Med learning platform and all about the updated programs and what is all happening day to day. You can check there. And also there will be the feedback link form. Yes, thank you, Jay. You have been very prompt. So the feedback link has been put in the chat box. Click that form and fill the form to get the participation certificate for this webinar. Thank you so much. And let's get ready for the Q&A. So let me check the Q&A portal here. Some have asked Dr. Wasim's presentation will not be sharing as a PPT, but still Dr. Wasim's session, this particular webinar, all the webinars, all our Skills for webinar will be in the YouTube. So you can even search for Skills for Med in YouTube so that you can look into the entire presentation again and again, and then you can have all the understanding. It's not about this 1 hour. Again, you can whenever you find some time, you can go back and you can listen to this webinar. Thank you so much. And you have any questions right now, you can raise your hand and you can ask directly to Dr. Wasim.
Usually the questions, they would like to have some ECG in their hand and ask the question. So,
ask the question.
Yeah.
Yes, doctor. Yes. Okay. Sir, there is one question. Can you tell us about override pacing?
Okay. Again, override pacing, you can use it for tachycardias which are not settling down. Again, so this is, I wouldn't like to confuse the participants. This overdrive pacing or override pacing, you do it only when there is the heart rate, the rhythm is so high that you're unable to control it. So when we talk about pacing at a basic level, you need to remember that pacing is done when the heart rate is slow. So only when when we talk about pacing, you have a bradycardia with a heart block. Bradycardia causing symptoms, or you have a heart block, like complete heart block or a second degree type 2. You have one of those heart blocks. Here you give pacing. For tachycardias, you will think of synchronized cardioversion first. If synchronized cardioversion is not working, you will think of antiarrhythmics. If antiarrhythmics is also not working, then you will think of overdrive pacing. I will usually get a cardiology consult before I do overdrive pacing. Any other questions?
Yeah. No, doctor. I think this is all the appreciations are coming up in the chat box. There was one question which you have resolved now. Yes. And also in the YouTube, I'm equally looking like a lot of participants in our YouTube channel who's looking live now. Yes. Yes, doctor. There is no questions in the YouTube portal even. I think you have cleared them during the webinar, you have cleared them with putting the ECG and asking them to resolve that or to identify it. And you have given them what has to be the immediate action to be done when they see such ECGs. So I think they all are clear with that. So still anyone wanted to have a direct interaction? If not, then we can
there's still a lot of ECGs which I haven't covered, like evolved MI. Someone is asking about an evolved MI. So you see those Q waves. So again, there is a lot of things. There are still ECG is a whole ocean which you can go on reading for your entire life. But I focused only on the life-threatening ones, the critical ECGs which you need to immediately intervene or bring it to notice of someone. Okay, so that is why I focused on those. Again, there are a lot of topics there. Definitely electrolyte. Someone is talking about electrolyte imbalance in ECG also. Yeah, so definitely probably at another session, I can talk to you about all those, what electrolyte changes are there in ECGs, and what happens in toxicology. There are still a lot of interesting things, but this is for a general audience, and I think at a general audience, this knowledge would be perfect, and probably advanced ECG at a later session. Yes.
Yes. Thank you. So you're also very active looking at the chat box and answering them, rapid, fast, like looking at there. So this was like 1 hour webinar. As you all know, all our webinar participants know, this is a 1 hour webinar. We have confined to this time limit. Otherwise, Dr. Wasim would have taken the session even more extensive. So this is confined to 1 hour just to interpret the basic ECG things. So I think so we can also, as you have requested, we can put forth or look forward for the future sessions with Dr. Wasim. Thank you so much, Doctor. Thank you for your time.
Thank you for the opportunity.
And thank you for this insightful session. And we'll be inside the Zoom room. Doctor, thank you for your time in your busy schedule. You have made this 1 hour dedicatively for Skills for Med webinar participants. And I hope you also have equally enjoyed how the way our participants have interacted with you. Thank you so much, Doctor.
Thank you.
Yes. Yes, Doctor. Doctor, you can leave if you want,
okay.
because the Zoom room will be open until they have completed the feedback form. Yes.
Yeah. Thank you.
Thank you, Doctor.